ऐसा कोई सर्कुलर तो आया नहीं हमें कि रिकॉर्ड होना है नहीं होना है, हमें तो कोई इन्फॉर्मेशन नहीं है ना। तो आप बता दो क्या है इन्फॉर्मेशन। हाँ तो फिर anyway, uh, so systemic sclerosis, we have two phenotypes. The one is the limited cutaneous and second is the diffuse cutaneous systemic sclerosis. Okay, so when should we consider that patient might be suffering from systemic sclerosis? So there has to be two different means indicators. One most prominent is that patient must have Raynaud's phenomenon. So diagnosing scleroderma without any history of Raynaud's is a very rare phenomenon. So at least the patient must be having a Raynaud's phenomenon to be considered as a part of systemic sclerosis. Okay, and the second is that patient should have any positivity to consider a diagnosis of systemic sclerosis. Okay, second last, please come and sit in the front. Yes, you. Yes, please come forward. So, so we'll start by considering what is Raynaud's phenomenon. Okay, so we all know that there is as a part of thermoregulation, there is a network of subcutaneous and deeper arterial network, and as a part of thermoregulation, we control sometimes the body controls physiologically the blood flow to the extremities to conserve the core temperature. Okay, so that is a part of the natural homeostasis, conservation of core temperature. Okay, so what happens then when there is a disruption of this normal physiology, when it becomes when there is a cold, obviously as a part of conservation of core temperature, the blood will be diverted from superficial surfaces to the deep vascular network, leading to conservation of heat. So there is a normal homeostasis, normal preservation of core temperature. Okay, but what happens when it becomes pathogenic? Even for less temperatures and even with emotional stimuli, sometimes there will be vasoconstriction in the peripheral arteries. So what happens when there is a vasoconstriction of the peripheral arteries? It will lead to classically it has been described in three phases. Okay, and when there is a vasoconstriction, it will lead to pallor of the extremities. Okay, there will be severe pallor of the extremities. After that, when the vasoconstriction dissolves, because at the time of vasoconstriction at initial phase there will be pallor. So because of the lack of circulation, there will be stasis and increased deoxygenated hemoglobin will be there in the extremities, leading to cyanosis. And after that phase of vasoconstriction is over, there is accumulation of the vasoactive amines, cytokines in the periphery, will lead to reactive dilation of the vessels, leading to redness and pain. So these three are the triphasic characteristic Raynaud's or classical Raynaud's has these three phases. Okay, so it will have first phase of pallor because of vasoconstriction, followed by cyanosis, and on restoration of blood flow there will be erythema and redness and pain. So this is the characteristic phases. So so whenever a patient presents with this complaint, then I will discuss when do we consider that the response to be pathologic. Then we'll consider that this group of patients should be considered to be a case of systemic sclerosis. Okay, so we'll come to that, but just discussing the pathogenic features or pathogenesis of systemic sclerosis. It's a polygenic disorder. As for any other autoimmune disorder, most of them have multiple components. For example, they have a genetic predisposition, they have some predisposing environmental factors, and there may be there are some host factors, like for example microbiota, infections. Those factors might be there. Hormonal, for example, in females, for example, the most autoimmune disorders are more common. So combining these multiple factors of environmental exposure, genetic predisposition, and host factors like microbiota, hormonal factors, etc., there is a predisposition to develop systemic sclerosis. So the concordance in monozygotic twins is only 4.7%. So the concordance in monozygotic twins is a rough investigation of the genetic contribution of the genetic component for pathogenesis of any disease. Okay, so a lower concordance can be termed as a lower genetic, because both the twins have the same genetic constitution, but only the concordance is only 4.7%, means which implies that there are many other non-genetic probably factors, maybe some epigenetic factors, we can't say, but environmental factors, host factors are also important in pathogenesis of this group of disorders. So there can be occupational exposures like silica, polyvinyl chloride, epoxy resins, welding fumes, solvents, aromatic hydrocarbons may have a putative role. So there may be some drugs also which are known to cause a scleroderma-like phenotype. So those are bleomycin, pentazocine, cocaine, appetite suppressants, which were earlier linked to the development of pulmonary artery hypertension. Okay, so even gadolinium contrast in patient with renal failure has been known to develop nephrogenic systemic fibrosis. Okay, so various drugs, occupational exposures can be linked to development of fibrosing conditions. Okay. So the pathogenesis basically it's a vasculopathy, microvasculopathy. There will be immune dysregulation, and fibrosis are the hallmarks of this condition. Okay, so at the initial phase there will be hyperreactivity, while fibrosis and atrophy occur in the later stages. In a initial vascular injury in a genetically predisposed individual may trigger functional and structural vascular alterations, which may lead to inflammation and autoimmunity culminating in fibrosis. Okay, so initial phase maybe probably they are more functional derangement in the form of increased vascular reactivity, while at the later stages there will be structural alteration because of the deposition of collagen and other extracellular matrix causing fibrosis. So this is one of the graphs. You can see there can be, in the early phase there can be vascular injury and endothelial activation. This leads to there will be secretion of endothelin-1 chemokines. There can be secretion of thrombin, thromboxane. All this will lead to recruitment of inflammatory cells, autoreactive inflammatory cells. At the end there will be fibroblast activation, which leads there will be myofibroblast transformation and excessive extracellular matrix formation. So this probably shows the entire origin of this pathogenesis probably start with the endothelin injury, with the activation of autoreactive T cells and B cells, with secretion of several cytokines like transforming TGF beta, interleukin 13-6. There will be a phenotype of pathogenic fibroblasts, which are called myofibroblasts, and they in turn elicit certain extracellular matrix excessively, and this leads to the phenotype of tissue fibrosis. So because of the fibrosis and widespread capillary loss, there will be obliterative vasculopathy and of small and medium sized arteries, and because of the decreased vascularization there will be decreased ability to repair the tissue. Okay. So because of the because in systemic sclerosis, for example, there will be digital ischemia, chronic digital ischemia, fibrosis of the vessels, decreased vascularity, etc. It leads to digital ulcers, telangiectasia, myocardial injury, or there can be other. It's not limited to subcutaneous tissue. It can also involve other capillary beds. So patient can also have pulmonary artery hypertension. Patient can also have myocardial fibrosis, myocardial injury. So the thing is what you can say is that there is a diversion of the immunological response toward the pro-fibrotic cytokines. For example, interleukin 4, 13, 33, TSLP, etc. So as there is also activation of the autoreactive B cells, there is increased production of autoimmune antibodies like anti-SCL70, anti-centromere, etc. Okay, so there is a whole network of both adaptive as well as innate immunity which acts to develop the phenotype of this condition. So just to enumerate the various autoimmune antibodies which are present in these conditions and the characteristic clinical associations. Okay, so the anti-DNA topoisomerase 1, or which is also known as SCL70, is typically associated with diffuse cutaneous phenotype. Okay, so it is associated with the tendon friction rubs, digital ischemic ulcers, scleroderma, extensive skin involvement. There can be early interstitial lung disease, and there can be cardiac involvement. Okay, so all those features are characteristically associated with diffuse cutaneous scleroderma, and which in turn has this antibody. Anti-centromeric antibodies are characteristic of limited cutaneous systemic sclerosis, distal ischemic ulcers, which is associated with distal ischemic ulcers, calcinosis cutis, isolated pulmonary artery hypertension, while renal crisis is rare in this subgroup of systemic sclerosis. Okay, so earlier we used to use the term crest, in which there was a collection of clinical features which we clubbed together in a crest, and it was considered to be typical of limited cutaneous systemic sclerosis. But now this term is not much propagated because we think that it is perceived that this group of clinical, like calcinosis cutis, Raynaud's, GRD, can also be seen in both the subtypes, means both this diffuse cutaneous as well as limited cutaneous. Okay, so you can consider it like that CRAS is may be considered a characteristic feature, more characteristic in limited cutaneous, but it can also be seen in diffuse cutaneous. So it's not exclusive presentation of limited cutaneous systemic sclerosis. Third antibody is anti-RNA polymerase 3, which can be seen in diffuse cutaneous scleroderma, and it is characteristically associated with renal crisis. Okay, so the antibody which is associated with increased risk to develop renal crisis is anti-RNA polymerase 3 and not anti-DNA topoisomerase 1. It's an MCQ question, but anyway, so it is also associated with development of rapidly progressive skin involvement, tendon friction rubs, gastroesophageal, mucosal, there may be antral venous malformations. It can be paramalignant also. Digital ulcers are rare in this association, are rare with this group of antibodies. There can be anti-U3, RNP or fibrillary, which can be associated with pulmonary artery hypertension, ILD, scleroderma, etc. So the most important thing you need to remember, these groups of antibodies can be seen in association, but top two are probably the most important to remember or recognize. So subtypes we can consider in these 4 subtypes, we can consider them. So patient can have pre-scleroderma, in which there is only Raynaud's phenomenon and some nail bed capillary changes. Okay, so there are only few sites in the human body where we can actually directly visualize the capillaries. So one is the right ana, and second is a nail bed. Okay, so whatever obliterative arteriopathy which we want to see can be first might be first visible in the nail beds. Okay, if patient with Raynaud's phenomenon and nail bed changes may precede the other typical clinical features like digital ulcers and maybe digital ischemia. So in addition on that patient may have autoimmune antibodies present. So patient may have autoimmune antibodies present for several years before the actual clinical symptoms or before the clinical disease occurs. Okay. So so coming to the diffuse cutaneous, diffuse cutaneous implies that both upper limb, lower limb can be involved, both proximal means above elbow and above knee involvement of the skin will be there, truncal involvement will be there, face can be involved in both limited as well as diffuse cutaneous. So there is a diffuse involvement of the skin all over the body, especially if trunk is involved and above elbow, above knee skin involvement is there, we think more in terms of diffuse cutaneous. Okay, while if it's limited to below elbow, below knee and trunk is spared, we'll think more in terms of limited cutaneous scleroderma. Okay, so sometimes in early phase of acute tissue edema we can find tendon friction rubs. Okay, so when we palpate the tendons during contraction and relaxation, we can sometimes feel that it's a palpable sign. Okay, so these rubs can be palpated when we sometimes in the acute phase, when there is a involvement of the tendons, we can have this tendon friction rubs palpable on clinical examination. Okay, so compared to limited cutaneous, there can be early interstitial lung disease. Okay, so when you learn about the pathology of pulmonary lung involvement, so there are two major groups. One is the obstructive airway diseases like COPD, emphysema, and bronchitis. The other group is that which involves the interstitial parenchyma of the lung, which is subgroup, which is equivalent to saying of like interstitial lung diseases. So this group of disorder is scleroderma is associated with interstitial lung diseases. So there is a parenchymal fibrosis rather than a large airway involvement. There is a parenchymal fibrosis, you can say. So in addition, it is diffuse cutaneous can be occasionally or rarely associated with oligouric renal failure, which is known as scleroderma renal crisis. There can be, as we had discussed, that myocardial fibrosis can also be a feature. There can be gastrointestinal involvement in the form of there can be gastric antral vascular malformation or GAV. There can be pseudo obstruction of the bowel. Okay, there can be, which can lead to blind loop syndrome, microbial overgrowth, and several clinical manifestations thereof. So we have to consider that scleroderma is not just involvement of the skin. There are serious consequences in the form of pulmonary involvement, cardiac involvement, GI involvement. Okay, so all those have to be considered whenever patient comes to you with scleroderma. When we perform the microscopy of the nail bed, you can see that there are capillary nail fold capillary dilation and dropouts, and SCL70 antibodies can be present about 60 to 70% of these patients. So you have to understand that though these antibodies are specific, they are not very sensitive. So if those antibodies are absent, you still can diagnose that patient to have systemic sclerosis. Okay, so if present, they are very specific for systemic sclerosis, but their absence does not rule out systemic sclerosis. Okay, you have to still consider and manage the patient as systemic sclerosis. Now, in contrast, in limited cutaneous scleroderma, the involvement, as I had just mentioned, that involves distal to elbow, distal to knees. It can involve the face, but there is truncal sparing. Okay, so in contrast to diffuse cutaneous, the lung involvement per se is delayed, while in diffuse cutaneous systemic sclerosis, the pulmonary artery hypertension is usually secondary to interstitial lung disease. So what is pulmonary artery hypertension? So we know systemic BP, systemic hypertension. So similar to that, there is a pulmonary artery hypertension. Okay. So one of the most important causes of pulmonary hypertension actually are lung pathologies. So if there is fibrosis, hypoxia, there will be some vasoconstriction, increase in pulmonary artery resistance, leading to secondary pulmonary hypertension you can cause. Okay? So in diffuse cutaneous scleroderma, we have pulmonary artery hypertension secondary to interstitial lung disease. So the pulmonary artery hypertension is secondary to lung involvement and hypoxia, etc. While there are a group of disorders in which there is intimal thickening medial sclerosis of pulmonary arterioles leading to increased pulmonary vascular resistance leading to pulmonary artery hypertension. Those are termed pulmonary artery hypertension, primary pulmonary artery hypertension. So in diffuse systemic sclerosis, there may be PH secondary to interstitial lung disease. Okay, while in limited cutaneous systemic sclerosis, there will be pulmonary hypertension, which is considered maybe primaries can also be seen. Okay, so in addition, there can be skin calcification, telangiectasia, there can be nail fold capillary dropouts, as is seen in diffuse cutaneous systemic sclerosis. The characteristic antibody which is seen in limited cutaneous systemic sclerosis is anti-centromeric antibodies. Okay. So it is also seen in a large majority of this group of patients, but even this antibody may be present, may be absent in a small subgroup. So absence should not lead to, you should not deny the diagnosis even if these antibodies are absent. There are rare patients in which there is no skin involvement predominant, but there may be definite Raynaud's. They may have lung involvement, lung involvement, extra dermatological involvement in the form of renal crisis, cardiac or GI disease. So those are a rare subgroup. So which we call scleroderma, sign scleroderma, means scleroderma without its dermatological findings, we can say that, but it's an uncommon minority of this group of disorders. So just to summarize, skin duration is means trunk is involved in proximal skin areas are involved in diffuse, while they are spared in limited cutaneous. Raynaud's phenomenon usually may be present for many years before the clinical diagnosis of scleroderma is made in limited cutaneous variety, while usually Raynaud's phenomenon is concurrent with the clinical diagnosis in diffuse cutaneous sclerosis. Okay. So pulmonary fibrosis is frequent and early in diffuse cutaneous, while it is occasional and moderate classically in limited cutaneous. So why I am stressing on this point is because most of the things you will need to prognosis of the patient, prognosis of the progressive organ involvement depends on this phenotype of the patient. So pulmonary fibrosis can be tends to be frequent and early in diffuse cutaneous, while it is occasionally or late in limited cutaneous. Similarly, pulmonary artery hypertension may occur, but it is more commonly because of lung involvement, while pulmonary hypertension can be frequent and late, but may be isolated without any interstitial lung disease in limited cutaneous. Scleroderma renal crisis is very rare in limited cutaneous, but it may occur in about 10 to 15% of the patients in diffuse cutaneous variety. Similarly, calcinosis QT is frequent in limited cutaneous, while it is infrequent in diffuse cutaneous. The characteristic autoantibodies present are anti-centromeric in limited cutaneous, while topoisomerase 1 or anti-SCL70 or anti-RNA polymerase 3 are more characteristic of or specific for diffuse cutaneous systemic sclerosis. Now the most important, because the patients come to you with Raynaud's, the most important thing you have to understand is which not all patients with Raynaud's will have connective tissue disease, or they may not have systemic sclerosis. So, which group of patients with Raynaud's should be considered pathologic or may be considered to be associated with connective tissue disorders? So, uh, so, so primary Raynaud's or Raynaud's disease, or versus secondary or Raynaud's phenomenon in connective tissue disorder or any other pathologic diseases. Mostly, the primary Raynaud's is just mostly a discomforting Raynaud's phenomenon in young patients, usually symmetrical in onsets. Okay, while Raynaud's secondary Raynaud's may be more common in older age groups, and it may be asymmetric. Though it can be symmetric, asymmetric Raynaud's should also always be considered for as a pathogenic or as a part of secondary Raynaud's. So usually in primary Raynaud's, there is only mild symptoms, like patient will have cold intolerance, patient may have just bluish discoloration of digits, but usually there is no tissue damage, so there is no ischemic changes, for example. So there is so whenever if patient has any ischemic changes like digital ulcers, or if patient has any severe changes, for example gangrene, then that is always a feature of secondary Raynaud's. Okay, so when we perform a nail bed capillaroscopy, the nail fold capillaries are preserved in primary Raynaud's. While sometimes we have to do, for example, if patient comes to you with Raynaud's and we are doubtful whether it's actually pathogenic or secondary, we look at the nail fold capillaries, and if there are capillary dropouts, we can be sure that the most likely the Raynaud's is, or it may help us to further may help in the further workup of this group of patients. Okay, so second is if patient has any second symptoms like polyarthralgia, or patient has any oral ulcerations, malar rash, Sjogren's symptoms. So Raynaud's phenomenon, secondary Raynaud's, is not exclusive to systemic sclerosis only. It can be present in any other connective tissue disorders also. So whenever patient has other features of any other connective tissue disorders like polyarthritis, oral ulcers, malar rash, or Sicca symptoms, or if there is obviously a classical skin change of scleroderma, then you can consider that it's most likely to be secondary Raynaud's. Another important thing is that obviously if patient has connective tissue, patient of secondary Raynaud's with connective tissue disorders may have ANA positivity. Okay, so important thing so there are some certain important clues. For example, so asymmetric Raynaud's or Raynaud's with any critical distal ischemia, nail ulcers, or ischemic damage to the finger should not be labeled to primary Raynaud's. It needs further evaluation for connective tissue disorders and other secondary causes for management. Okay, so one of the prime importance is to distinguish primary Raynaud's from secondary Raynaud's. So as we can see in those figures, so there is shiny skin, atrophic skin, contextures. In severe cases, there may be also acrolysis or distal resorption of the digits. Okay, so this is the classical Raynaud's. There is a asymmetrical involvement. There is a pallor phase only which has been demonstrated. Okay, so sometimes we can have this the mouth opening because of the characteristic facial involvement. There can also be this ragates formation, microostia. Patient will have difficulty in opening the mouth completely. There will be ragates. So all those this will be part of the typical scleroderma facies. There may be some vascular malformation in the form of telangiectasia, as we can see in this figure. So there can be nail bed, there can be macrohemorrhages, there can be capillary dropouts. In very severe cases, sometimes patient do present with severe gangrene. Patient have loose digits because of the aggressive disease. Many patients will have just tip non-healing ulcers or shallow ulcers at the tip of the digits, which are indicative of chronic ischemic injury. Okay. So this figure only shows the what all organ systems can be involved. So, we can understand that most common problems which are there are the after skin. They are the GI complications. So GARD is very common. Patient will present with complaints of reflux disease. Many patients do present occasionally. They have not been diagnosed scleroderma and they present with lower esophageal stenosis. Okay. So sometimes, any patient who present with means lower GI motility disorders, acid reflux disease with Raynaud's should always be investigated for systemic sclerosis. So GI complications are one of the most extradermatological complications. There can be musculoskeletal problems in the form of myalgia, arthralgia. Many patients will have symptoms of inflammatory arthritis. Sometimes there is overlap with the myositis. There is inflammation of muscles, so patient may also have myopathic weakness when it's as a part of overlap syndrome. So interstitial lung disease is one of the most troubling because many patients are incapacitated because of the severe lung involvement and they have restriction of activities even at young age because of the severe interstitial lung disease. Then patient can also have cardiac involvement, patient can also have renal failure. So coming to some of the individual organ involvement, lung involvement can be in the form of, as we had discussed, patient can have interstitial lung disease, patient can have pulmonary artery hypertension. There are several patterns of involvement of lung in interstitial lung disease. Interstitial lung disease is not a single disease, it's a spectrum of disorders in which the predominant involvement is the interstitial, lung interstitial is involved. So NSIP pattern is one of the pattern, but you don't need to memorize at this time, it's for later date. So as for any lung, as is expected, if patient has parenchymal fibrosis, okay, the patient will have exertional dyspnea and patient will not tolerate exercise. So one of the most important typical findings on clinical examination is described on auscultation, which is the Velcro crepes. Okay, so whenever you auscultate these patients, chest auscultation is done carefully. Sometimes we can hear this type of crepes, which are described as a Velcro. When you rip off a Velcro or the crepes you hear, you can describe it maybe. So in contrast to obstructive airway diseases, okay, the characteristic pattern on pulmonary function test, which you will learn you must have learned in your physiology classes, or you will learn in your physiology classes about the pulmonary function test. Here in ILD we have a restrictive pattern. So FE1 by FEC ratio is FE1 by FEC ratio is more than 0.8 with decrease FE1. So you need not memorize. If you remember, the homework today will be to go back and look at the pulmonary function test and just look what are the difference between the parameters in restrictive versus obstructive lung diseases. Okay, so this is the homework for you today. No need to memorize it now, but just understand that the pulmonary function test will be indicative of interstitial lung diseases. So pulmonary hypertension, as we had discussed, can occur in about 15% of the patients. They may be secondary to ILD or they can be primary PH. So as for ILD, patient will have exertional dyspnea, and sometimes, because just like in systemic hypertension, there will be pressure overload on the left side of the heart. Similarly, in pulmonary artery hypertension will lead to pressure overload of the right side of the heart. Okay, systemic hypertension causes LVH pulmonary hypertension will cause RVH, right, ventricular hypertrophy, and in chronically when it is high, it will ultimately lead to failure and dilation of the right ventricle, which is known as the right side heart failure. Okay. So, uh, so technical definition you can leave it for now, but you can understand that pulmonary hypertension is one of the features of scleroderma. So this list of GI manifestation I just want to enumerate. You can, whenever you evaluate any patient, you can just focus on them. So starting from oropharynx, there can be diminished oral microostia, or there can be diminished oral aperture. There may be dry mouth. There may be gingivitis. Many patients have this swelling difficulty. In esophagus, characteristically, patient may have gastroesophageal reflux. Patient may have dysphagia, strictures. Sometimes as you might learn, that chronic reflux leads to metaplastic changes in the esophageal mucosa, which is known as Barrett's metaplasia. In stomach, there can be gastroparesis. There can be gastric antral vascular ectasia, which might be a source of GI bleed in this group of patients. Because of this vascular malformation, which may sometimes bleed, leading to anemia. Small and large intestine can be involved in the form of impaired mobility, so patient can have sometimes pseudo obstruction. Because of the decreased motility, there will be colonization with we can say pathogenic microorganisms, or there can be bacterial overgrowth. It can lead to diarrhea or constipation alternating. There can be pneumatosis. Rarely, I have not seen, but pneumatosis intestinally has been described in literature. There can be malabsorption. Sometimes there can be colonic pseudo-diverticular. So just to enumerate this, so in findings in GI, just few lines on scleroderma renal crisis. So important thing to understand is that it's a thrombotic microangiopathy. Okay, it presents with very high BP with progressive renal failure. So patient will have hypertensive crisis with acute onset renal failure, and pathogenesis wise, it is a thrombotic microangiopathy. Okay, so it is most common in diffuse cutaneous systemic sclerosis. It occurs in the early first few years of diagnosis of this diffuse cutaneous systemic sclerosis. It occurs in the early diagnostic years. So as we had discussed, anti-RNA polymerase is the predisposes to development of this clinical condition. Okay. Now, one of the important things to understand, which is for most connective tissue disorders, autoimmune disorders, steroid is an integral part of management. So sometimes we may have to use steroids in high doses to control the underlying inflammation in most autoinflammatory disorders. But we have to be very cautious when we use high dose steroid in systemic sclerosis because of this predisposition. So when we give high dose steroids in diffuse systemic sclerosis, especially in the early diagnostic early diagnostic phase, we may precipitate systemic what we call scleroderma renal crisis. So high dose steroids have to be used very cautiously in systemic sclerosis patients, especially diffuse cutaneous systemic sclerosis, because high dose steroids can precipitate the scleroderma renal crisis. Okay, so other predisposition are male gender and tandem friction rubs. The treatment consists of using ACE inhibitors, endothelin antagonist, and sometimes renal replacement therapy are needed. So, but it's very rare. We have seen only 1 or 2 cases in the past 10 years as a clinical presentation. So, still you have to be very cautious. Any patient with scleroderma presenting with acute onset, uncontrolled hypertension, progressive renal failure, you have to be very vigilant that patient might be having a scleroderma renal crisis, because early intervention with ACE inhibitors and endothelin antagonists may probably prevent the progression of that. Okay, so So coming to the classification criteria for systemic sclerosis, as discussed and stressed earlier, diagnostic criteria are different from, means classification criteria are not equivalent to diagnostic criteria. Okay. So, but still, we can use them as a important clinical tool to understand what all the characteristic features of scleroderma are. Okay. So if the skin thickening of the fingers of both hands extend proximal to the MCP joints, then probably that is enough to diagnose in the presence. So important caveat is that it should not be explained by any other clinical condition. Okay, after ruling out, it should not be better explained by any other clinical condition. So all classification criteria have this caveat whenever you use them. So if patient has a skin thickening but it's not explained by any other, it cannot be better explained by any other medical condition, then probably it can be diagnosed or classified as a systemic sclerosis. Okay, so when it is just distal to MCP joints, then we should consider other involvement, like fingertip lesions if they are there, if there is telangiectasia, if there are abnormal nail foot capillaries, if there is lung involvement, if there is Raynaud's phenomenon, and in the presence of scleroderma associated antibodies. So all those needs to be contributed in together to make a classification into scleroderma. So coming to the last part is when you made a diagnosis of systemic sclerosis and you want to manage various conditions. So starting with the Raynaud's. So Raynaud's is an abnormal hyperreactivity of the digital vessels. So we can use some smooth muscle, means drugs which cause dilation of the vessels, or vasodilators which we can use. So calcium channel blockers are the important vasodilators which we can use to treat Raynaud's phenomenon. Okay, so as can be seen, the CCBs are the initial drug of choice. Okay, so if patient does not respond, then we can add fluoxetine and ARBs. So if patient still have troublesome Raynaud's despite the use of calcium channel blockers, then we can also use phosphodiesterase 5 inhibitors like sildenafil, tadalafil can be used. Occasionally, if patient has very life-threatening, limb-threatening ischemia, if patient has severe progressive vasospasm leading to gangrene of a distal digit, sometimes we can also use IV prostacyclin analogs. So as you might have read in your pharmacology, or you will read in pharmacology, that there are two types of prostaglandins. Some are pro-inflammatory, some are anti-inflammatory and vasodilatory. So prostacyclin are that group which is vasodilatory, anti-inflammatory. So we can sometimes use those commercial preparation of prostacyclin or prostacyclin analogs in very severe cases of distal gangrene. Okay, so epoprostenol, prostanoids, some prostacyclin analogs can be used. Okay, another important thing is the lifestyle changes. You have to avoid cold. You have to use gloves. You have to avoid those activities which causes cold exposure. Okay, those are the lifestyle changes which are integral part of this. Okay, so for pulmonary involvement, we can use certain immunomodulator drugs like cyclophosphamide or mycophenolate mofetil. Rarely, those patients who have very progression of systemic sclerosis associated ILD patient may be considered for stem cell transplant. Okay, for pulmonary artery hypertension also, the most important thing is the treatment of the underlying cause. Okay, if it's present because of interstitial lung disease, we have to treat interstitial lung disease aggressively. If it's primary pulmonary artery hypertension, then we can use vasodilators. The most important therapy are phosphodiesterase 5 inhibitors and endothelin receptor antagonists. So endothelin is also a vasoconstrictor. You can see cytokine, and there are certain antagonists like ambrisentan, etc., which can be used and which are used for management of pulmonary artery hypertension. Okay. If patient has skin and musculoskeletal involvement, if patient has predominantly joint involvement, if patient has inflammatory joint pain, then we can also use methotrexate. And in some case in which there is some case, if you want to halt the progression of skin manifestation, we can also use mycophenolate, mofetil. So if you want to use steroids, we always have to use low dose steroids. So classically, low dose steroid is labeled as 7.5 milligram of prednisolone equivalent per day, less or less. Okay, so we can use low dose steroids occasionally in this group of patients. Okay. Cardiac involvement, depending on the degree of symptoms, sometimes we may have to use, if patient has symptoms of heart failure, we may use diuretics. If patient has active ongoing myocarditis with other features, other organ involvement, we can also use immunosuppressive therapy. Calcinosis involvement in systemic sclerosis is frustrating to treat because very refractory to treatment sometimes, but sometimes we have used bisphosphonates and chelating agents, but it is sometimes difficult to treat. GI treatment. For GI treatment, we can have for reflux. If patient has a reflux of gastric contents into the esophagus, we can use proton pump inhibitors, or we can use prokinetic drugs. Okay. Sometimes it may be used along with lifestyle changes. Okay. So just this is the overview. No need to memorize at this time. Just you have the purpose of this lecture is to give an overview of the organ involvement in systemic sclerosis, what are antibodies which are present. The most important thing to remember at this time is the difference between the primary and the secondary Raynaud's. Okay, so no need to memorize at this point. Roll number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, who's 34? 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53,
54, 55, 56, 57, 58, 59, 60, 61, 62,